Vigilance Week 2021. We already have had 5 days of continued CME of this virtual CME series, where we have seen 4 excellent lectures and a equally wonderful panel discussion, all of which are available on YouTube. So tonight we have our very own Dr. Shambho Shamrat Shamazdar, or Shambhoda as we lovingly call him. He is a renowned speaker who is an medical education enthusiast. He is currently as a clinical pharmacologist in School of Tropical Medicine, Kolkata. He is one of the main figures behind this whole iNovoCare E-Academy, which is the medical education wing of iNovoCare Health Sub Solutions, which is the co-organizer of this entire event, along with the Netaji Subhash Medical College, Patna, Beta Patna. So without further ado, let us begin today's evening with Dr. Shambho Shamrat Shamazdar. Today's topic is managing drug-induced diseases, a clinical pharmacological approach. So Dr. Shamazdar, the stage is yours.
Thank you very much, Rohan. Thank you for your kind words. So, welcome respected delegates. Today we'll discuss about drug-induced disease. We all know that drugs are used for diseases. So today the topic will be, what are the diseases that is produced by drugs? So this is a very famous quote by Molière, who was a French dramatist. He told once, to undergo treatment, you have to be very healthy, because apart from your sickness, you have to withstand the medicine. And we also know this famous quote by Paracelsus, who told that poison is in everything and no thing is without poison. Actually, the dosage that makes it either a poison or a remedy. But this statement is not always true. Why it is not always true, that also we will have some discussion on that. Because apart from the dose, even if a very smallest dose of paracetamol can act as a poison. So if we go by the ancient Indian literature, there also we found that they had given extremely importance on drugs which can acts like a poison. So this was mentioned in Charak Samhita, and even in the Ayurvedic literature, drug literature, 500 AD, Bhagavatta, who was a renowned Ayurvedic physician that time, described adverse events, contraindications, and delayed adverse drug reactions to various Ayurvedic group of drugs. So India has a very strong heritage.
I'm sorry if our program's chairperson, Dr. Tripathi, has joined.
Yeah,
I'm
please.
so sorry to
welcome you, sir. Welcome you, sir.
Yeah, all right. You please carry on. I'm sorry I was a little late. Please carry on.
Okay, sir.
Okay, I'm there.
So this is a very extremely, we are proud that India, which has a strong history in previous years about this adverse drug reaction, now first time in world actually observing Pharmacovigilance Week. So from 17th September to 24th September, we are observing Pharmacovigilance Week. And the theme is, we have to keep patient safety at center. So now this diagram, it is taken from Goodman-Gilman. So in the y-axis, we can appreciate the response of the drug, and in the x-axis, we can see the dose of the drug. Now, here, that means when dose is 0, that means the response is death. That means response is maximum bad response. So, if just taking, I am giving one example, a type 1 diabetic patient. So, we all know that for type 1 diabetes, insulin is extremely important. Without insulin, the patient will die. So now if the patient does not have any dose of insulin, insulin dose is 0, persisting for that. So due to adverse response, that means here not adverse drug reaction, here we can say adverse patient response, the patient will die. This is the area where we can say the threshold for adverse response. So anything beyond that is adverse, anything below that is desirable. So if we increase the dose of the drug, if we increase the dose of insulin in that particular type 1 diabetic patient, so the adverse patient experience subsequently will decrease. And now here at this dose, the patient will have the optimum patient response, optimum desired response. And again, if we see, if we increase the dose further from this line, this x-axis, so what happened? The patient will again face adverse patient experience. So we all know if the insulin dose is increased than the optimum dose, it will lead to hypoglycemia, and ultimately at some level of dose, high dose, it will cause again death. So this U-shaped curve is very important to appreciate, because if we can appreciate this U-shaped curve, then we will find where should we remain, that region of homeostasis. That is most important. How we can balance between adverse patient experience and desired patient experience. And this is the key. Anything above this line, that will cause adverse patient experience, or sometimes we also called it as adverse drug reaction. So I will discuss some case that has been seen in different OPDs, and with that I will try to collaborate some drug concepts of drug-induced diseases. So this is a 29-year male presented to clinical pharmacology OPD. He had erectile dysfunction for last 2 months, married for last 6 months. Medical history is suffering from migraine. Also for urticaria, he was taking clemastine 10 milligram once daily for last 3 months, and Practine 4, that means the cyproheptadine 4 milligram twice daily for last 1 month. For migraine, he was on amitriptyline 25 milligram once daily. Apart from that, he is also taking pantoprazole domperidone fixed dose combination for last 6 months. So we all know this chart, the IIEF-5 score, and initially the IIEF-5 score was 9. So this is very important to understand, also known as anticholinergic burden score. So if we calculate the anticholinergic burden for this particular man, then we will find he is taking amitriptyline along with clemastine. So 3 plus 3, the score is 6. So he is taking a high anticholinergic burden drug. Apart from that, if we just consider that he is also taking pantoprazole-domperidone combination. And we also know that domperidone can cause erectile dysfunction. And if we are having difficulty or there is something which blocking the parasympathetic nervous system function, that also can block the, or that also can be detrimental for erectile function. So what happened? We can state like that he is suffering from drug-induced erectile dysfunction. So deprescribing clemastine and amitriptyline, adding some newer antihistamine, that is bilastine 20 milligram and flunarizine for migraine, and also asked to take antacid SOS basis. So if we can just see the need of that pantoprazole domperidone, that also increased because of that high anticholinergic burden. So if in a prescription the anticholinergic burden is 3 or more, that can cause parasympathomimetic adverse drug reaction leading to different drug-induced diseases. So just deprescribing those group of drug, adding alternate group of drug can be beneficial for this type of patient. And we can see after 1 month, the IIF-5 score was quite improved. It was 22 without any medication. Now coming to the case 2, a 45-year-old female presented to emergency with altered consciousness. She was suffering from hypertension, depression, and alcohol abuse, on venlafaxine 150 milligram once daily, omeprazole 20 milligram once daily, and losartan 50 milligram twice daily. Now, she also overused bisacodyl for weight loss. As she has a history of constipation, someone prescribed bisacodyl, and over the counter she took bisacodyl, and she had a perception that if I have a loose motion or then that can cause weight loss. So she took bisacodyl over the counter. Now the patient's partner found her behaving abnormally for few days, no signs of intentional intoxication. In the previous days, there was no history of fever or any other illness. Physical examination, confused and disoriented in time or place. Also, she spoke with a slurred speech. Blood pressure was elevated, 160 by 112. Pulse rate high, tachycardia. Temperature was 36.7. Oxygen saturation was okay, 95% at ambient air. She had a dilated pupil, dry tongue, red skin, and urinary retention of more than 1 liter. GCS was okay, E4, M6, but V3. And suspected to have a visual hallucination because she was talking to some imaginary pupil. Other neurological examination done at emergency was unremarkable. Now, the question is, this is a very important approach to drug-induced disorder. Specifically, this is known as toxidrome approach. That means toxic substance syndrome. We know how to manage syndromic approach in different disease. So this is the toxidrome approach. That means the syndromic approach, the syndrome, the symptoms, the clinical fingertip that can give us clue that which type of toxic substance the patient is consuming. So may I request our respected delegates, if you, I can stop for 30 seconds. In the chat box, if you can just give your option Is it a cholinergic toxidrome? Is it an anticholinergic toxidrome? Is it a serotonin syndrome? Or is it a sympathomimetic toxidrome? So I will stop here for 30 seconds. Request you to answer in the chat box. Then we will go further. I am just going back to the case. Just see. I am requesting you to make your answer in the chat box. So on venlafaxine, omeprazole, losartan, overused bisacodyl, then few days behaving abnormally, no fever. In emergency, there is an altered consciousness. Patient is confused, disoriented in time and place, slurred speech, blood pressure high, tachycardia, temperature 36.7 degrees Celsius, saturation 95%. There is dilated pupil, dry tongue, urinary retention more than 1 liter found in the ultrasonography in that emergency room. GCS was E4, M6, V3, visual hallucination, and talking to imaginary pupil. By that they are telling, but another neurological examination was unremarkable. So may I request to, can I see the chat box? Okay, so anticholinergic syndrome, sympathomimetic, and anticholinergic syndrome. So I think maximum response that came towards the anticholinergic toxidrome. So let's see the toxidromes. So this is a cartoon where we can easily identify which type of toxidrome we are talking about. So in case of anticholinergic toxidrome, what happened? There is a high heart rate or tachycardia and high BP, no change in the respiration, temperature little bit elevated, pupil dilated, the IPS, intestinal peristaltic sound, diminished quite, and it is a silent abdomen, we can say. Diaphoresis will be not there, dry skin. And also, if we consider the bladder, there will be urinary retention. So this is the symptoms of anticholinergic toxidromes. Then cholinergic, generally what happened? Pinpoint pupil, that is the diagnostic, and very high bowel sounds. So IPS will be plus, and also there will be diaphoresis, and also different parts, there will be lots of secretion. In case of opioid toxidrome, there will be little bit bradycardia, respiration will be here diminished, the skin will be cool. Again, this will be typically pinpoint pupil, much more constricted than the cholinergic one also. Again here, we will not found the bowel sound that much. There will be dry skin. In sympathomimetic toxidrome, there will be high in blood pressure, tachycardia, increased respiratory rate, temperature will be increased. Again, dilated pupil. There will be IPS will be plus, and there will be diaphoresis. And if there is sedative hypnotic toxidrome, then we will found again the heart rate, blood pressure little bit decreased, not that much affected. Respiration will be, respiratory rate will be decreased. The patient's body temperature will be little bit low. Pupillary no change happen. And also the bowel sound will generally not affected to little bit sluggish, and skin will be drier. So by this way, if we just consider our patient, so there is mydriasis, there is tachycardia, anhidrosis, hypoactive bowel sounds, specifically urinary retention, there is hallucinations. So we can say our patient is suffering from anticholinergic toxidrome, and main feature of that particular patient is due to that overuse of bisacodyl, which has an inherent anticholinergic property. Apart from that, venlafaxine, which is a very important SNRI, but as this patient is taking omeprazole, omeprazole has a property to decrease as it is the specific CYP inhibitor. So there will be a little bit higher concentration of venlafaxine, and venlafaxine also have a anticholinergic property, though it is little compared to other tricyclic antidepressant. So this is a way how we can approach in emergency patients who to identify which toxic substance the patient is ingesting, and we can have an idea, and then we can plan for specific therapy. Also, there is another important syndrome that need to cover, that is serotonin syndrome. There are patients, there are lots of case reports. Patient will take a tyramine containing food. The patient is on multiple permutation combination of SNRI, tricyclic antidepressant like drugs. On top of that, for 2 to 3 days, patient took linezolid and present with these all symptoms, and they are mostly suffering from serotonin syndrome. So this is a way by which we can also understand or diagnose serotonergic agent overdose. First of all, if there is a spontaneous clonus, if it is present, then it is a serotonin syndrome in background of temporal relationship with serotonergic drug. If it is no, then we have to see the ankle and to try to induce clonus, or we have to check the ocular clonus. If it is yes, then we should check for agitation or diaphoresis or hypertonia and fever. If it is yes, then also that's tell us that the patient may be suffering from serotonin syndrome. Otherwise, there are some other possibilities. But again, if there is tremor, there is hyperreflexia, then also we can think of serotonin syndrome. And this is an important drug-induced disorder we need to detect quickly, because otherwise, if the time will go, we may lose our patient. And in nutshell, this is a way by which we can differentiate between different serotonergic origin, that means serotonin syndrome like other features, like from serotonin syndrome, how we can differentiate anticholinergic syndrome, malignant neuroleptic syndrome, and malignant hyperthermia. I think this slide is very useful. You may take a snapshot. I am not going in details of this particular slides due to time constraint. Now coming to my next case. Again, this case is already this is a part of one case series that I had submitted in JAPI, and they have accepted that. So this is a 56 years old female, pain both knee joints, but for last 5 days, there is severe weakness, pedal swelling for 5 months. There is history of knee joint, both knee joint osteoarthritis, hypertension, type 2 diabetes, BMI 36. So if we go by the different medications, lots of medications we can see here. The thing is that the patient is taking a fixed dose combination which contains trypsin, bromelain, rutoside along with diclofenac twice daily. And what happened? There is some pedal swelling. For that particular pedal swelling, she was taking by herself furosemide 40 milligram once daily. Now, this lab report, if we go by, then we will found the glycemia is totally uncontrolled, 8.6%. There is hyponatremia, hypokalemia, creatinine value is 1.4, On top of that, you can see what are the medicines the patient is on. eGFR is 41.9, but other routine tests are normal. So this is the pill burden. Now you can just see at that eGFR value, the patient is taking glimepiride 4 milligram, metformin 2 gram, pioglitazone 15 milligram, amlodipine 5 milligram, pregabalin. So now if we just see the adverse effects the patient was suffering, that means why the patient came to us? Due to severe weakness. So now you can well appreciate that this severe weakness is due to hyponatremia. Sodium value is 121. Why this sodium value becomes 121? Because for last 7 days, the patient took furosemide 40 milligram. Now if you ask that why the patient took furosemide 40 milligram, to reduce that pedal edema. Now ask why that pedal edema happened. You will get a lot of drug in this particular list which can cause pedal edema, including amlodipine, pioglitazone like drugs. Also the pregabalin has some property. The thing is that to note another cause of pedal edema is maybe the renal cause. At that eGFR value, the patient is on full dose of metformin. So that also can deteriorate renal function. On top of that, patient is taking a FDC containing diclofenac. So lots of factors are present in there. So the main problem lies in the medicine list. So if we analyze the medicine list properly and advise our patient, that can omit many symptoms. So what are the reconciliation done for that particular patient? Just omit all drugs, only for anti-diabetes management. We can see the obesity. So once weekly GLP-1 RA was prescribed, along with the metformin dose was halved from 2 gram to 1 gram. Initial 2 weeks, as there was a hyponatremia, background hyponatremia. So it was initiated with a basal insulin, then followed by canagliflozin 100 milligram once daily. For pain, all the others non-evidence-based medicines was withdrawn. Paracetamol was given for twice daily. The main problem for osteoarthritis, one of the main problem for osteoarthritis in this particular lady is due to that body weight. If we target that body weight, reduce that body weight, the pain will automatically gone. So we need to address that issue holistically. So another important issue that is very critical, that the patient was taking calcium carbonate, on top of that also taking some PPI. And we all know that the salt, if we use calcium carbonate along with PPI, the calcium will not absorb adequately. So we need to change the salt, calcium citrate, that is why it was changed. Apart from that, obviously the dosing of atorvastatin need to be considered, and the domperidone was withdrawn. More focus on lifestyle modification, physiotherapy, and orthopedic surgeon consultation. So what happened after 6 months? The BMI decreased to 28 kg per meter square. Pain gone, no pedal swelling. Creatinine value was 1.2. eGFR was improved. And most importantly, the HbA1c is improved. So this is the effect. If we can understand the pathology, if we can understand the pathology lies with drug, then if we take appropriate action, the pathology will be will gone. So this is happened to this particular patient, as already we had discussed. This is known as prescribing cascade, and the careful medication history is extremely important to understand this prescribing cascade. And if we understand prescribing cascade, then we can omit many drug-induced disorders. So this is the case 4. A 38-year-old female taking alpha-methyl dopa during third trimester of her pregnancy. 3 months after delivery, she had visited doctor, developed red maculopapular scaly rash in sun-exposed parts, persist for 7 to 10 days each time, go away on its own. Rashes have also began to appear on her cheeks and above her eyes on either side of forehead. Proteinuria, hemoglobinuria, low PCV, features suggestive of hemolytic anemia, and one history of seizure. So lab investigation suggests an ANA positive, anti-dsDNA negative, and antihistone antibody was not done. So that it was diagnosed as drug-induced lupus. So again, this is very important. We need to understand the pathology behind any disease, and we need to consider a drug, and we should suspect drug accordingly, the disease pathology. So here we all know that alpha-methyl dopa has a potential to produce drug-induced lupus, and these symptoms that happen that are undergone further investigation and which suggest drug-induced lupus. So now case 5, a 22-year-old male, history of multiple drug allergy, known patient of asthma, allergic rhinitis, last 10 years on allergen immunotherapy, intranasal corticosteroid, ICS, LABA, occasional intake of LTRA with levocetrizine. The first episode of drug allergy was 12 years back, ingestion of PCM within 30 minutes, lose consciousness and attend hospital emergency by 2 hours, and BP was critically low, 60 by the diastolic blood pressure was not measurable. So resuscitated with anaphylaxis protocol. Next episode, amoxicillin clavulanic acid FDC, 9 years back, took for chest infection. After 3 doses, from second day, developed fever, malaise, vomiting, and joint pain. From 4th day, there was maculopapular rash with burning sensation, began symmetrically on the face and the upper part of the chest with involvement of oral mucosa, admitted in hospital, so diagnosed with Stevens-Johnson syndrome and managed conservatively. 3rd episode, drug allergy test was done. That was from blood, and specific IgE was not found to be elevated to penicillin or cephalosporin group. So that is why with that report, when he had visited one doctor 4 years back due to fever with productive cough, the cefodoxime was initiated. But after 15 days, severe arthralgia and maculopapular rash appears over upper limbs and face. Parents admit her in hospital. Total there is leukocytosis, eosinophil count 20%, SGPT, SGOT high, so diagnosed as DRESS. So this is why it is important. Now, if we just consider, I am just skipping this slide, but want to give importance on this J-SCAR criteria. This is a very useful criteria by which we can diagnose DRESS. And by this slide, this picture can help us to understand whether the patient is suffering from DRESS or Stevens-Johnson or acute generalized exanthematous pustulosis or erythroderma. So the important is that we need to give, we need to see the temporal relationship with drug. So in case of DRESS, it is 2 to 6 weeks. SGS will start a little bit earlier. So in this particular patient, there is one event of SGS, we can appreciate that, and one event of DRESS, and another incident was anaphylaxis. So my question is to this august audience, it is just brainstorming like that. I can wait for a 30 seconds again. So first, just write down 1 dash which type of hypersensitivity, 2 which type of hypersensitivity, and 3 which type of hypersensitivity reaction. I think all of you will agree that this particular person is suffering from drug allergy or drug hypersensitivity reaction. Now, if we just think that which type of hypersensitivity reaction the patient is suffering, then we can then we can have a further discussion. So may I request you, number 1 episode, which type of hypersensitivity reaction? 1 for -1 or 2 or 3 or 4. Second episode is 1 or 2 or 3 or 4. Third episode, 1 or 2 or 3 or 4. So after that, we will move for further discussion. May I wait for maybe 30 seconds? So here we can see the type 1 hypersensitivity reaction. Type 2 hypersensitivity, type 1 hypersensitivity reaction, what happened? The Ig receptor is occupied by Ig antibody. Then when the allergen will enters, they will be coupled between 2 Ig antibody, and that lead to some conformational changes into mast cell and cause release of different mediators, including histamines. So this is the type 1 hypersensitivity reaction. But for type 1 hypersensitivity reaction, another step is very important, that is sensitization. So there is a role of T cell. T cell and antigen presenting cell. Antigen presenting cell will take the antigen and that will be presented to T cell. T cell will check what type of antigen it. If they recognize it as self and as self, then the reaction will automatically stop. But if it not recognize that self, it will tell the B cell to produce IgE instead of IgG. There will be class switching due to some release of interleukin 4 or interleukin 5. And there will be class switching from IgG to IgE. And that IgE will sit on the Fc epsilon receptor over the mast cell. And in case of type 2 hypersensitivity, what happened? The red blood cells is occupied by antigen, and that antigen may be penicillin, and that antigen will be attached with Fc portion of IgG antibody, or sometimes IgM antibody also can come there, and they invite either natural killer cell or the complement system to kill the cell. So this is also known as cytolytic reaction, type 2 hypersensitivity reaction. Next, type 3 hypersensitivity reaction. In the circulation, there will be antibodies, specifically the IgG antibody, and that IgG antibody will bind with antigen, and they will form a complex, antigen-antibody complex, which is circulating in nature. The difference between type 2 and type 3 hypersensitivity reaction, in type 2 hypersensitivity reaction, there also be an antigen-antibody complex, but that is on the cellular surface. But here, the antigen-antibody complex will be circulated in the blood, and they will be deposited maybe in the joint or any other tissues. Now, there will be invitation to the complement system. There will be invitation to different macrophages, monocytes. So there will be lysis by the activation of this particular Fc gamma cells, and there will be local inflammation and phagocytosis. So this is type 3 hypersensitivity reaction. And in case of type 4 hypersensitivity reaction, again, there will be the antigen will be presented to T cells, naive T cell, and then after this presentation from antigen presenting cell, the T helper cell will decide what type of signal 3 it will produce, what type of cytokine it will produce. According to that cytokine, there will be either Th1 cell or Th2 cells or Th17 cell. And according to that, it will produce other cytokines, and that will activate macrophage. And following that, the type 4 hypersensitivity reactions will happen. Now, I think there is any thing comes into the chat box. No. So first reaction, which is from paracetamol, we can say it is probably type 1 hypersensitivity reaction. The maximum chance is type 1 hypersensitivity reaction. Now, while talking about Stevens-Johnson syndrome and DRESS, we are talking about type 4 hypersensitivity reaction. And the previous case, that pregnant lady, the alpha methyl DOPA, the drug-induced lupus erythematosus. So that is the typical case of type 3 hypersensitivity reaction. So with that, we can go forward. I think the next slide. Yes, so again, this is a very important concept, that pharmacology and immunological receptor concept. So this is an important molecule, that is HLA molecule, which helps to present antigen to the T cell. And according to that particular HLA molecule, generally here we are talking about CD8 mediated disease. So HLA type 1 we are talking about, or MHC class 1 we are talking about, they will produce that CD8 mediated cytotoxicity. And this is a drug dependent one. So depending on the MHC portion, HLA allele, the different drugs may react differently. So this is pharmacological and immunological concept, immunological receptor concept. And by this HLA phenotyping, we can predict, though we are talking that drug allergy is an unpredictable one. When we classify drug allergy, it comes under the type B reactions, Bijare type of reaction. So this is unpredictable episodes. But if we have a HLA phenotyping, we may predict this type of unpredictable episodes. And this is a list of genetic variation by which we can predict. So this is another important issue when we are talking about allergy, drug allergy, how to differentiate between allergy and pseudo allergy. So symptoms are same, synonymous in the pseudo allergic reactions also. And if you just see, when we are talking about the paracetamol, that incidence, the first episode, we talk, it is most probably type 1 hypersensitivity. Why I told most probably type 1 hypersensitivity? Because that can also be this pseudo allergic reactions also. For that, we need to do some thorough workup to differentiate between allergic reaction and pseudo allergic reaction. So here the key change between allergic reaction and pseudo allergic reaction is Ig mediated. Allergic reactions are Ig mediated, whereas pseudo allergic reactions are Ig independent mechanism. They generally happen due to complement pathway, or sometimes direct stimulation of the mast cells, or due to some exogenous products. So what is important while talking about drug-induced disorder, we need to consider drug as an etiology. And for that, what is the most important part? History taking. Detailed medication history is extremely important. There is some role of clinical methods. As already we had discussed, eliciting clonus, that is very important. And some other tests. We also need to understand by whether the patient is suffering from drug-induced disorders, if there is any other disease present or not, that we need to exclude. For that, clinical methods have a great importance. Apart from that, there are some lab tests, obviously different routine blood tests, a complete hemogram, PCV values, absolute eosinophil count, to liver function test, creatinine values, all are very important in specific cases. Skin prick test, if we are suspecting type 1 hypersensitivity reaction, then the skin prick test give us some clue whether the patient is suffering from this drug mediated type 1 hypersensitivity reaction. So in our case, that specific Ig level was high, not high to penicillin and cephalosporin, but that patient have allergy, drug allergy with manifestation of DRESS or Stevens-Johnson syndrome in case of amoxicillin, clavulanic acid, and also cephalosporin, cefodoxime. Why this happened? Because that is type 4 hypersensitivity reaction. type 4 hypersensitivity reaction, there will not be elevated specific IgE level, or skin prick test will not be possible, not positive. So for that, one test is very important, but we don't have much data on that. That is lymphocyte transformation test. And we need more data, more research on this particular test. Apart from that, patch test can identify type 4 hypersensitivity reaction. Trip test has very immense importance to understand whether the patient has anaphylaxis or not. Because if a patient has anaphylaxis, the trip test level will be very high. But this high level will again come back to the normal value if the time goes on. So we need to test trip test value very early. So delayed testing of trip test will not give any clue. So this temporal relationship between the suspecting drug intake and the trip test estimation is very important. If that time period is much more, then I think there will be no value on this costly test. HLA phenotyping, already discussed the importance that pharmacology, immunological receptor mediated reactions. Pharmacogenomics has very important role. Therapeutic drug monitoring can give us clue whether the drug now remaining in the toxic level or not. Autonomic neuropathy screening is very important. There are lots of cases we found in case of diabetes. We found that patient has diabetic autonomic neuropathy. And while going details of his medication history, we found the patient has some drugs which is causing autonomic neuropathy. So just deprescribing those drugs, the patient becomes, patient's autonomic neurofunctions become normal. So indirect pharmacokinetic, pharmacodynamic models are there. In case of diabetes, the continuous glucose monitoring can help us. Ambulatory blood pressure monitoring is very important. Pheno, we are using inhalational corticosteroid. The effect we can transcribe into the pheno value. Yes, in case of drug-induced heart disease, the role of ECG and echo has its own value. Drug-induced lung disease, because drug-induced lung disease is a very important chapter where we saw there is a decrease in total lung capacity. And for that, this DLCO and PFT has a very important role. But what is important, that is the history taking. We can say like that history taking is investigation, diagnosis, and treatment in evaluating drug-induced disorders. So we need a detailed history taking. We need a complete medication history. And apart from that, so we need a high index of suspicion. And this is a way, this chart we can found from one very important group book that is on drug-induced diseases. In this, this chart, we need to take the medication history. I am not going in details, but this chart we can follow. And just giving him emphasize, while taking medication history, the financial issues are very important to note also. Out-of-pocket medication cost, that is important because that has a direct implications on adherence. So causality assessment scales, these are the well-known causality assessment scale. Now coming to my last case, that is a 36-year recently married T2DM admitted for CABG. So T2DM for 4 years, smoker for 10 years, hypertension for 3 years. Maternal history of death due to massive heart attack at the rate of at the age of 54 years. Dyslipidemia last 1 year, but not taking atorvastatin 20 milligram after marriage. That is for last 6 months. Medicines are on sitagliptin metformin combination, telmisartan 40 milligram. So poor compliance to those antihypertensive drugs since marriage. So what happened? We had asked, why you are not taking atorvastatin and blood pressure medication regularly? And that is one of the major reasons for admitting for CABG. So patient told this thing. So this is the, we can say, the social media, the WhatsApp university's result. the cholesterol is good for my mood, cholesterol is good for sex, high blood pressure medication can cause impotence. So we need to address this also. Unnecessary drug-induced, we are talking about drug-induced disorders, but sometimes some drugs should not be unfortunately stopped due to the fear of drug-induced disorders, and that is most important. And there are lots of scientific body which recommends that statins are safe. They have no effect on erectile function. And this is meta-analysis. I am not going in details, but this is our responsibility also. Yes, we have to talk about drug-induced disorders, but we also need to educate our patient that you are not suffering from drug-induced disorder. Otherwise, there will be some atrocity. So outcomes and endpoints, when we are talking about clinical outcomes, are not always equal to therapeutic or interventional endpoints. We need to give emphasis on patient-oriented evidences, because that matters rather than disease-oriented evidences. And we should have a smart therapeutic endpoint, specific, measurable, achievable, and agreed upon, realistic and time-bound. I am just giving one example from today's experience. One patient had called me. He told me that I am taking, he was a diabetic patient on anti-diabetes agent along with for hypertriglyceridemia, and there is a NASH. He was on saroglitazar. So he told me that when I am taking saroglitazar daily, that is causing some problem, some myopathy, like things in my myopathy. So what I am doing, when I stop it completely, the triglyceride becomes again very high. So I am now taking saroglitazar alternate day. That is not actually recommended. That is not present in our drug level. This is a totally off-level thing. But after taking alternate day saroglitazar, the patient is okay with triglyceride value. Triglyceride is normal. SGPT, SGOT is fine. And also she does not have that particular complaint, which he was faced repeatedly. So we have to be sometimes more patient-oriented, individualized. And these are the different intervention by which we can restrict drug-induced disease. And for that, we need to understand the medication-related problems and proposed interventions, whether there is we are using some drugs which has no indications, whether we are using some drugs, we need to use some drugs, but it was not prescribed, whether we are using some wrong drug regimen, whether we are over-prescribing or little prescribing, any adverse drug reactions or drug allergy we are missing, drug disease, drug food interactions, patient not receiving a prescribed drug due to adherence or sometimes economic causes, routine monitoring also missing to see whether there is some drug-induced disorders happening or not, or some overlapping adverse effects between multiple drugs. So these are the important area, and I am not going in details of this definition of adverse drug reactions. We know that, but yes, adverse drug reactions are also, we can say, drug-induced disorders. And for that, if we go through the WHO definition, that is a response to a drug that is noxious and unintended and occurs at doses normally used in man for the prophylaxis, diagnosis, or therapy of disease, or for modification of physiological functions. But if we go by this definition written in a published article by Edward Sayer, then we will find that noxious word was replaced an appreciably harmful or unpleasant reaction. So this makes little bit broaden the definition of adverse drug reactions, that resulting from an intervention related to the use of medicinal product, all medicinal product it includes, which predicts hazard from future administration and warrants prevention or specific treatment or alteration of the dosage regimen or withdrawal of the product. So my question is whether we can call adverse drug reaction as drug-induced disorders. So these are the different adverse drug reactions, type of adverse drug reaction, dose-related, non-dose related or bizarre type of, then chronic, that means dose-related and time-related. So that is due to long-term use of corticosteroid that causes hypothalamic pituitary adrenal axis suppression. Then delayed adverse drug reaction, time-related, that means teratogenesis, carcinogenesis like things. Withdrawal, if we withdraw that drug, that can cause adverse drug reaction, just like in case of clonidine, just withdraw, there will be hypertension. And this F is very important, failure. That means unexpected failure of therapy. That is generally inadequate dosing. So whether inadequate dosing we can call as drug-induced disorder, that is a question mark. All this from A to E, we can call it as drug-induced disorder. But this unexpected failure of therapy, whether we can call it as drug-induced disorder, that is a question mark. I will ask our respected chairperson, sir, to answer this and make us understand this concept. And with that, I again profusely thank Professor Shantanu Kumar Tripathi, sir, my mentor, my guide, because this new entity, during my DM training, he had given emphasize how to deal with these drug-induced disorders. And I think this is a very important entity. And while going through any disease, the etiology of drug we need to consider. With that, I thank you all. And may I request Professor Tripathi sir for further explanation.
Thank you very much, Dr. Shambhu. It was quite exhaustive, and you have very aptly used some cases and your own experience, in fact, while treating patients. And because of your clinical pharmacology background, you could identify the problems that are being created by astute history taking. You are very right. The diagnosis of drug-induced disorders is mostly by exclusion. And I always say that whenever a patient comes to any doctor and seek care for any kind of problem, the first thing should be done that is it by any chance possible that the problem is caused by any medication that the person might be consuming. Okay, so that means one needs to rule out always whatever might be the problem. Try to rule out whether the person is already taking some medicines for whatever reason, and whether such medicine intake could be responsible for the problem that he is presenting with. That ruling out is very important. For ruling that out, we actually need to have very in-depth and diligent history taking, okay, medication history taking. So that becomes the first thing. And then, of course, there are different algorithms or different applying your own experience and wisdom. You can try to zero down, narrow down. So that way, drug-induced disorder remains as a by default. It's a default differential diagnosis, I would say. And every time a physician is challenged with a patient situation, the physician is obligated to rule out the diagnosis of drug-induced disorder, the differential diagnosis of drug-induced disorder. Now, you have also very nicely pointed out that how to define what is drug-induced disorder. As a simple definition would be any problem that otherwise potentially has been caused by drug intervention or drug exposure. That could be a prescription drug, that could be OTC medicine, that could be caused by actually the adverse experience or adverse drug reaction. That could be also, say, toxic effects, although the prescribing dose is very much well within the intended therapeutic range, but for that particular patient, it could be supratherapeutic because of his poor liver or the kidney function. So all these actually have to keep in mind. You are just putting that whether we can consider adverse drug reaction and drug-induced disorder synonymously. So truly speaking, no, there is subtle difference. Yes, one can put it like this, that all adverse drug reaction could be considered as drug-induced disorder, but not necessarily all drug-induced disorders are caused by adverse drug reactions. By that, I mean that, say, toxic effects or the overdoses poisoning is not really by definition adverse drug reaction. Adverse drug reaction has a clear definition that it has to be within the intended therapeutic dose range. And even that definition will require some change when you think of using the drug in the pre-marketing setting, when we really do not know what is the therapeutic dose range and you are doing the clinical trials. The dose ranging studies, so say the phase 2 clinical trial, there we actually intend to identify the therapeutic dose. So there, if somebody is experiencing an adverse impact, so that is also an adverse drug reaction. So in a clinical trial setting, it is not, we cannot say that within the therapeutic dose range. So that there it will be at any dose. So drug-induced disorder will actually very umbrella kind of expression or a phrase that would include all kinds of drug-related problems, okay, whether prescribed or otherwise non-prescribed, but whether we can actually establish that some degree of association or some causality can be established. And there are different ways of causality establishment. We know not necessarily always they are very efficient to actually implicate a drug, and many a times it becomes very, very difficult also because of multiple drugs being taken together, and in the best interest of the patient it might not be always possible to do de-challenge, serial de-challenge, and that may be a agenda of a pharmacovigilance expert, not a clinician. And you are also right that when you say that if we are suspecting a drug-induced disorder, one of the first step in the management would be withdraw the drug, withdraw the offending drug. So that remains one of the very important steps, the first step probably. And in many cases, if it is really induced by the drug, and if you withdraw it, then naturally, if there is decline or if there is the patient gets better, then that would prove that disappearance of the problem on withdrawal of the drug. That is what is called de-challenge. On the other hand, there are also other extreme, like if the problem is being caused by lowering of the dose, tapering down of the dose, and there is a problem because of that, the question of de-challenge will not come. There rather it's the other way around. If you re-challenge and if there is betterment in the situation. So you cannot really think of a very simplistic kind of model by which you can say that yes, by following this, I will be able to diagnose drug-induced disorders. You have also very rightly mentioned about the different types of hypersensitivity reactions. And there also the history taking is extremely, extremely important. Over and above that, there is some limited role of the different laboratory investigations, special laboratory investigations. And this is an area it is still evolving. Okay, the different markers and the different investigations. You have also pointed out that HLA typing may also be to a certain extent predict certain type of drug hypersensitivity reactions. The other day somebody was sharing with me about somebody having a kind of drug hypersensitivity reaction from allopurinol, and the team of physicians, they were really unsure about whether it could be called Steven Johnson's or it is DRESS. You had mentioned about the the onset, okay, that in Stevens-Johnson's, the onset is usually 1 to 2 weeks, while in case of Grace, it is 2 to 6 weeks. But then there is some overlap. Somebody who is where the onset is 2 weeks. So it is not just by the onset that you can differentiate between the two. The other interesting thing is both of them are otherwise type 4 reaction, type 4 hypersensitivity. But it is interesting to note that while in Stevens-Johnson's, steroids are not to be used, steroids may otherwise cause an even adverse outcome. It's contraindicated rather. On the other hand, in Grace, steroids are to be used, and steroids remain the key drug of choice rather. And in fact, even after the person has been recovered from the symptoms, person is recovering, person has otherwise recovered, abrupt withdrawal of steroid may lead to relapse. So one needs to also be cautious about how to manage. So it is not just stopping the offending drug and automatically the patient will be all right. It's not really as simple as that. And then again, the long-term complications, okay, of drug-induced disorders. So drug-induced disorders, some of the acute manifestations or some of the acute problems with which the patient may present, but apparently there might be some recovery or some improvement in the patient's condition. But then there are also delayed complications or long-term complications which are not very uncommon in some of the, particularly the hypersensitivity type 4 in Grace. The other day also we were discussing about many a times these problems, they also are involving multiple organ systems. It is not, apparently it manifests with say skin problem, mainly skin presentations, dermatological presentations. But then it is the, truly speaking, there are multi-system involvement, multiple organ system involvement, and that may linger on for weeks and months. Okay, so one need to be cautious about them. So it's a very wide area. Only somebody only when physicians are very conscious about this and keep their eyes and ears open, and particularly be enough communicative with the patient, explain to the patient, takes a history patiently, and then only to a certain extent, even the hypersensitivity reaction to a certain extent, they can also be prevented. So it was otherwise very wonderful presentation. Let me now find out in the chat box if there are a few comments and questions. Quickly, maybe in another 5-7 minutes, we can try to address them.
Yes, yes. Sir, one thing just you had mentioned about that, the intended dose, drug dose at intended for therapeutic effect. Right. Or we can say the at dose normally used in man.
Absolutely. Yeah.
And
yeah.
that is the difference between adverse drug reaction and drug-induced disease. So that is one.
No, it's not. It's not. No, it's not difference. What I am saying that when you try to define adverse drug reaction.
Yeah.
Okay.
Yes, I understand. That means that is why you are telling that all adverse drug reactions are not drug-induced disorders, because
all adverse drug reactions will be also considered as drug-induced disorder, but all drug-induced disorders are not necessarily adverse drug reactions. That's what I say.
But I am coming to that, sir. Here, first of all, in the classification, there is another area, that is the unexpected failure of therapy in adverse drug reaction. That means the inadequate dosage of drug is not giving the benefit.
Absolutely.
Whether we can also tell this portion.
No, I tell you what. I tell you. I'll explain. When you talk of drug-induced disorder, we need to also expand it a little more. It is not just about the chemical or the biological drug. It is also the manner in which they are being used. So rather, more precisely or more correctly, drug-induced disorders are because of the intervention. Remember, it's not just the drug, but the intervention. When you talk of the intervention, that actually brings out the how you are using it. You are using it in a manner so that you cannot really expect the desired benefit. For the desired benefit, the kind of optimum dose that has to be used, you are using 1/4 of that dose, and there is the efficacy is not achieved. So patient is facing the music, patient is facing the problem. So that also should be classified under drug-induced disorder, because it is not just, when you talk of drug-induced disorder, it is not just the drug as such, but it is the context of use of the drug that is important. So similarly, when you talk of drug-induced disorder, if it is because of a host factor, or if it is because of an other, say, genetic factor, it is being caused. So how can you call it drug-induced? So it is not just the drug-induced, it is drug-use-induced disorder. More correctly, it is drug prescribing induced, drug dispensing induced, drug administration induced, okay, disorder. That should be rather a wider kind of definition of drug-induced disorder.
Yes, sir. So this definition of adverse drug reaction was made by Edward Zayer, and which is published in Lancet 2000 October. So we can see here the dose that was mentioned in the WHO definition long back, 30 years back, that was not here. So here they are mentioning that an appreciably harmful or unpleasant reaction that resulting from an intervention related to the use of medicinal product. So here use of medicinal product they have mentioned, and which predicts hazard from future administration, warrants prevention or specific treatment or alteration of the dosage regimen or withdrawal of the product. I think this definition goes more favor with that drug-induced disorder. And now we need to think that whether in the definition of adverse drug reaction, we may omit that portion also, that dose portion also, so that we also can include the toxic effect in
no, I tell you, the toxic effect, when you talk of problems that are created with the drug, say when you talk of unwanted effects of drugs, okay, broadhead is unwanted. When you are using drug, you are intending to get benefit. So intended effect, that is your desired effect, what you intended. And apart from the intended effect, any other effect the patient experiences, they are all unintended. Now the unintended effect, like a side effect, is also unintended. But the difference between a side effect and an adverse drug reaction is, side effect is non-noxious because it does not cause an injury. Side effects usually will not call for seek treatment for a side effect, and side effects are well tolerated. So this is about side effect, and usually it occurs at a lower dose. So these are side effects, and within the therapeutic dose also side effects can occur. But for side effect, usually we need not have to stop the treatment, switch to another treatment, or the patient need not have to seek treatment, or the physician need not have to offer treatment or give treatment. So side effects are not harmful. So this noxious word is very important. Noxious means damage, injury. So adverse effects are noxious effects, while side effects are non-noxious effects. That is the difference. And side effects are well tolerated, adverse effects are not. But then adverse effect, when you talk of adverse effects, that is in clinical trial, it is any dose. But when the drug is marketed, it is therapeutic dose range for that particular patient. Again, as I said, that you are very much well within the therapeutic dose range. For a particular patient, it is supratherapeutic. So you have to keep that into account also. So if it is supratherapeutic, whether you will call it by definition an adverse reaction, that also becomes an issue. So supratherapeutic dose, and because of that overdoses, if there is problem, by the definition we do not call it adverse drug reaction. That becomes under overdoses poisoning or overdoses toxicity. So the toxic effect, or rather poisoning, toxic effects, adverse drug reactions, and side effects. So they have very, very clear defined understanding and insights. We need to be very precise about that. Now the question is, the slide that you presented, that whether adverse effects and the drug-induced disorders are synonymous. There has been analytical reviews and essays in many literature that you can find out. On the particular article that you are referring to, we have to go through that article, how they have presented. But to my understanding, they are not synonymous. There are subtle differences. There are a lot of similarity, but they are not exactly same. So these are two distinct terms that are used to refer to the phenomenon of adverse drug reaction and the drug-induced disorders. Fine. Coming to one comment by Professor Parthore, requesting us to clarify the underlying basis of serotonin syndrome and what is the pharmacological basis of the same. As simple as that, because the name suggests the syndrome or the symptom complex can be explained by an excess of serotonin, excess availability of serotonin, whether it is reduced uptake of serotonin, whether it is excessive synthesis of serotonin, reduced metabolism or inactivation of serotonin. So there is more serotonin available, and all these symptoms you can explain by the serotonergic symptoms or serotonergic features. So when serotonin as a neurotransmitter 5-HT, it occupies or it attaches to serotonin receptors and stimulate the receptor, the kind of manifestations that are expected, it matches with that. And you can also think of using anti-serotonergic drug, okay, which will to a certain extent can take care of these symptoms. So that's what the serotonergic serotonin syndrome is concerned, and the mechanism is otherwise as simple as that. Next is, yes, there is some difference in neuroleptic malignant syndrome and the serotonergic syndrome. Yes, there is difference. They are not the same thing. Any other comment?
Can I ask a rejoinder?
Please.
Yeah, only to say that the serotonergic syndrome and the various manifestations that Shambhu very nicely put to us, how those are basically parasympathetic and sympathetic nervous system functions. Serotonin, how will it cause all that type of syndrome that we saw?
No, I was a little unmindful. I have not really followed the specific presentation of serotonergic syndrome, serotonin syndrome that Dr. Shambhu had presented today.
Yes, he gave a very good syndrome and all. He put it very nicely. I need to look at the slides again. He had a very good illustration. Just that in the clinical cases that I have seen, first of all, it's rare. So the second part of the question was, despite all these chemicals being used widely, we don't get it as frequently. Like we expect a cholinergic or anticholinergic, adrenergic or anti-adrenergic effects. Serotonergic effect is not that commonly seen. That was the one question. And secondly, the clinical manifestations of serotonin syndrome were to me more adrenergic or cholinergic or some sort of mixture of that. That was my cardinal question as to how a serotonin excess is causing all that. Shambhu might be able to answer that question.
Yeah.
Shambhu, what was your case?
My case was not on serotonin syndrome. I gave, because while talking about toxidrome approach, we also need to consider serotonin syndrome, because there are chance of multiple drugs concomitantly used by one patient and present to emergency with symptoms suggesting of serotonin syndrome. And it is not only the autonomic nervous system function, that is sympathetic, parasympathetic nervous system function. Apart from that, the higher function also involved in case of serotonin syndrome. But we found. And
the usual features of serotonin syndrome is hyperthermia, agitation, tremor, sweating.
Yes, sir.
Some of them will match with parasympathomimetic. Parasympatholytic. Like dilated pupil and all. But then these are all can be explained by serotonergic stimulation, serotonergic receptor stimulation.
At which level? At which points of the nervous system? Is it entirely limbic? Is it hypothalamic? That is what I wanted to, because I have seen these cases rarely and I've never understood them very properly. And it's like a pattern recognition of serotonergic syndrome in the right context, but the pathophysiology, because it's a clinical pharmacological forum. So I'd like to know about the underlying basis of the neurochemicals at play. If possible, we may not know, that's all right. Same thing happens in neuroleptic malignant syndrome and in the dopaminergic excess or dopaminergic reduced syndrome. So we, as I said in the question, it's the molar ratio is not followed. Like you expect giving more adrenaline or more acetylcholine and getting the response. Here, it seems to be slightly more complex, and the manifestations are through the autonomic nervous system. Most of the syndromes you talked about, apart from the CNS symptoms, which is actually a total cocktail of chemicals at play. So that was my actually need to understand, because these are quite common, often missed.
Sir, what is my understanding? The basis of this syndrome, serotonin syndrome, is more central. So
where?
That we need to explore, but it is more central because as there is compromised consciousness and other issues, so it is more central. Need to see the anatomy in more details, but that is
there are serotonergic distribution in the CNS mainly,